Welcome to this continuing education course on medical errors for Florida healthcare professionals. This course is designed to fulfill the mandatory 2-hour continuing education requirement established by Florida Statute 456.013 for all healthcare professionals regulated by the Division of Medical Quality Assurance. By the end of this course, you will have developed a comprehensive, evidence-based framework for understanding, analyzing, and preventing medical errors in your practice. Let's begin by outlining the learning objectives for this course. Upon completion, you will be able to differentiate between active errors and latent conditions within the context of the Swiss cheese model of accident causation. You will be able to identify the key steps of a root cause analysis investigation, from data collection to the development of causal statements. You will learn to select the strongest error reduction strategy for a given clinical scenario using the action hierarchy framework. You will be able to compare the principles of a just culture with a traditional blame culture in response to a medical error. You will learn to apply the SBAR communication tool, which stands for Situation, Background, Assessment, and Recommendation, to a clinical handoff scenario. You will recognize appropriate safety precautions for managing high alert and look-alike, sound-alike medications, commonly abbreviated as LASA medications. And finally, you will identify the 5 most misdiagnosed conditions in Florida as determined by the Florida Boards of Medicine and Osteopathic Medicine. Let's begin with our introduction to the patient safety imperative. The practice of medicine is an inherently complex and high-risk endeavor. Despite the profound advancements in medical science and the unwavering dedication of healthcare professionals, the potential for error remains a persistent and formidable challenge. A medical error is broadly defined as the failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. These events are not isolated incidents but represent a systemic global health crisis, exacting a devastating toll in terms of human life, patient trust, and economic resources. To fully grasp the urgency of the patient safety movement, it is essential to understand the scale of the problem. Data from leading global and national health organizations paint a sobering picture of the frequency and impact of unsafe medical care. These statistics are not mere abstractions. They represent millions of individual patients and families whose lives have been irrevocably altered by preventable harm. Globally, the World Health Organization has identified patient harm as the 14th leading cause of the global disease burden, comparable to diseases such as tuberculosis and malaria. The figures are stark. Around 1 in every 10 patients is harmed while receiving healthcare, and more than 3 million deaths occur annually as a direct result of unsafe care. In low and middle income countries, the situation is even more critical, with estimates suggesting that as many as 4 in 100 people die from unsafe care, and 2.6 million of these deaths are considered avoidable. The economic consequences are equally staggering. Unsafe medication practices and errors alone are estimated to cost the global economy $42 billion annually, which amounts to nearly 1% of all global health expenditure. When considering the indirect costs of lost wages, productivity, and long-term disability, the total economic burden of patient harm amounts to trillions of US dollars each year and potentially reduces global economic growth by 0.7% annually. Within the United States, the landscape is similarly concerning. The landmark 2000 report from the Institute of Medicine, now known as the National Academy of Medicine, titled "To Err is Human," first brought national attention to the issue, estimating that up to 98,000 Americans died each year due to medical errors. More recent studies suggest the number may be significantly higher. One analysis estimated that over 200,000 patient deaths annually were due to preventable medical errors, while another widely publicized study in 2016 placed the figure at over 250,000 deaths per year, which would make medical error the 3rd leading cause of death in the US, behind only heart disease and cancer. While the precise number of deaths remains a subject of academic debate due to methodological challenges, the underlying reality is undeniable. A significant number of patients die from preventable harm in U.S. hospitals each year. This statistical uncertainty points to a deeper systemic issue in how medical errors are tracked and reported. A major limitation is that the International Classification of Disease coding system, used to assign a cause of death on death certificates, has limited ability to capture most types of medical errors. Consequently, deaths due to medical error are often attributed to the patient's underlying condition, leading to systemic underreporting. This denominator problem suggests that the officially documented statistics likely represent only the tip of the iceberg. For the practicing clinician, this means that the absence of reported errors in one's own practice or facility does not signify an absence of risk. The true scope of the problem necessitates a proactive, systems based approach to safety rather than a reactive response to documented failures. The impact on the American public is widespread. A 2017 national survey conducted by the Institute for Healthcare Improvement and the National Patient Safety Foundation found that 21% of adult Americans report having personally experienced a medical error, and 31% have been involved in the care of someone who experienced an error. These are not rare occurrences, but common experiences that erode public trust in the healthcare system and cause lasting physical, emotional, and financial harm to patients and their families. Let me provide you with a summary of the global and national burden of medical errors. In terms of global patient harm, 1 in every 10 patients is harmed during healthcare. Regarding global deaths from unsafe care, over 3 million deaths occur annually, with the World Health Organization estimating 2.6 million deaths per year from medical negligence. For U.S. deaths from medical error, estimates range from the Institute of Medicine's 498,000 annually to more recent studies suggesting over 200,000 to 250,000 annually, making it a potential third leading cause of death. The global economic impact is substantial, with medication errors alone costing an estimated $42 billion annually, and the total indirect cost of harm amounting to trillions of dollars each year. Looking at the U.S. public experience, 21% of American adults report having personally experienced a medical error. In terms of preventability, over 50% of patient harm is considered preventable, with half of that harm attributed to medications. Now let's discuss Florida's legislative response and the mandate of Florida Statute 456.013. In response to this public health crisis, the Florida legislature has established specific educational mandates for licensed healthcare professionals aimed at fostering a culture of safety and reducing the incidence of preventable harm. This statute requires that, as a condition of biennial license renewal, all healthcare professionals regulated by a board under the Division of Medical Quality Assurance, or the department if there is no board, must complete a 2-hour continuing education course related to the prevention of medical errors. This requirement applies to a broad range of professions, including but not limited to medicine, osteopathic medicine, occupational therapy, physical therapy, midwifery, and dietetics and nutrition. The statute is highly specific about the core content of this mandatory course. It explicitly requires the curriculum to include a study of 3 key topics: root cause analysis, error reduction and prevention, and patient safety. The deliberate inclusion of root cause analysis in the statute is particularly significant. It represents a legislative acknowledgement of the principles of modern patient safety science. By mandating education in root cause analysis, a methodology focused on identifying systemic vulnerabilities rather than assigning individual blame, the state of Florida is signaling a critical shift in regulatory expectations. This is a move away from a purely punitive model and towards a systems-based approach to error analysis. This legal requirement elevates the understanding and application of systems thinking from a best practice to a core professional competency for all licensed practitioners in the state. Fulfilling this mandate is not merely a bureaucratic hurdle, but a professional obligation to adopt a more sophisticated and effective framework for thinking about and preventing medical errors. Furthermore, the statute includes a crucial provision for physicians licensed under the Board of Medicine and the Board of Osteopathic Medicine. For these professionals, the course must also include information relating to the 5 most misdiagnosed conditions during the previous biennium, as determined by their respective boards. This requirement ensures that the educational content is directly relevant to the most pressing and frequently encountered diagnostic challenges leading to disciplinary action in Florida. Finally, individual professional boards may add their own discipline-specific requirements. For example, the Board of Occupational Therapy requires the course to include content on contraindications and indications specific to occupational therapy management, including medication and side effects. This layered approach ensures that the course is both broadly applicable across the healthcare spectrum and specifically relevant to the unique risks and responsibilities of each profession. Now let's move into Section 1, which covers a systems-based approach to understanding medical errors. The foundational principle of modern patient safety is a radical departure from traditional views of error. For decades, the response to a medical error was to identify the individual who made the mistake and apply blame, retraining, or punishment. This bad apple theory, however, has proven to be an ineffective and often counterproductive approach to improving safety. It fails to recognize that humans are inherently fallible and that errors are rarely the result of a single individual's incompetence or negligence. Instead, most errors are symptoms of deeper underlying weaknesses within the complex systems of care delivery. A fundamental cultural change within the healthcare environment is the shift from focusing on character and people-related flaws to rigorously analyzing system and process flaws. This new paradigm requires a commitment to discard the instinctive need to assign blame and instead embrace a blameless exploration of the systems, processes, and mechanisms that have failed to prevent human error. This approach does not absolve individuals of professional responsibility, but it reframes the central question from who is at fault to why did our defenses fail? This systems thinking approach is the core of human factors engineering, a scientific discipline that has been instrumental in improving safety in other high-risk industries like aviation and nuclear power. Human factors engineering considers human strengths and limitations in the design of interactive systems that involve people, tools, technology, and work environments. It recognizes that healthcare is delivered by real and fallible human beings and seeks to design systems that are resilient to error. Rather than expecting flawless performance from people working in flawed systems, human factors engineering aims to create systems that optimize safety and minimize the risk of error. It achieves this by analyzing the demands of a clinical task, including the physical effort, cognitive workload, team dynamics, and environmental factors like noise and lighting, and designing processes and tools that support safe and effective performance. This shift has profound implications for how healthcare organizations learn and improve. A culture that blames and punishes individuals for errors creates an environment of fear. In such an environment, clinicians are less likely to report errors or near misses, fearing reprisal. This suppression of reporting is not merely an issue of workplace morale, it is a critical system flaw in itself. When errors go unreported, the organization is robbed of the opportunity to learn from them. The underlying system weaknesses that contributed to the error remain hidden, unaddressed, and poised to cause harm again. Therefore, a punitive blame culture is a direct and significant threat to patient safety, as it actively prevents the organization from identifying and correcting its own vulnerabilities. Now let's discuss the Swiss cheese model of accident causation in a clinical context. To visualize how system flaws lead to patient harm, safety expert James Reason developed the Swiss cheese model of accident causation. This model has become a cornerstone of patient safety education and provides a powerful conceptual framework for understanding the nature of medical errors. In this model, an organization's safety system is likened to a stack of Swiss cheese slices. Each slice represents a layer of defense or a barrier designed to prevent a hazard from reaching a patient. These defensive layers are diverse and can include several categories. Technology, such as computerized physician order entry with clinical decision support, barcode medication administration systems, and smart infusion pumps. Policies and procedures like mandatory surgical timeouts, protocols for medication reconciliation, and staffing policies. Training and education, ensuring clinicians have the necessary knowledge and skills. Supervision and leadership, providing oversight and fostering a culture of safety. And teamwork and communication, utilizing structured communication tools and promoting collaboration. Crucially, no single defensive layer is perfect. Each slice of cheese has holes, which represent weaknesses, gaps, or failures in that particular defense. These holes are not static, they are dynamic, constantly opening, closing, and changing position due to shifting clinical conditions, resource constraints, and human factors. An adverse event occurs only when the holes in all the defensive layers momentarily align, creating a trajectory of accident opportunity that allows a hazard to pass through all the barriers and cause patient harm. The classic example of the 1977 Tenerife plane crash illustrates this perfectly. A combination of fog, communication misunderstandings, and procedural violations, representing multiple holes in the cheese, aligned to cause the deadliest accident in aviation history. The Swiss cheese model is particularly useful for understanding the two distinct types of failures that contribute to an adverse event: active errors and latent conditions. Active failures, also called active errors, are the unsafe acts committed by people who are in direct contact with the patient or the system, the frontline providers at the sharp end of care delivery. Active failures take a variety of forms, including slips, which are actions not carried out as intended, like pushing the wrong button, lapses, which are memory failures, like forgetting a step in a sequence, and mistakes, which are forming a wrong plan, often due to inadequate knowledge or misinterpretation of information. These errors have an immediate and direct effect on the patient. For example, a nurse administering the wrong medication is an active failure. While these actions are the most visible cause of an accident, they are rarely the sole cause. Latent conditions, also called latent errors, are the accidents waiting to happen. They are the hidden, underlying failures within the system that create the conditions for active errors to occur. Latent conditions are often created by designers, managers, and high-level decision makers, those at the blunt end of the organization. They may lie dormant within the system for days, months, or even years before they combine with active failures and local triggers to cause an accident. Examples of latent conditions include inadequate staffing or excessive workloads, poorly designed medical devices or software interfaces, incomplete or ambiguous procedures, ineffective training, breakdowns in communication channels, and a punitive organizational culture that discourages reporting. The true power of the Swiss cheese model is that it shifts the focus of error prevention from trying to perfect human behavior, which is an impossible task, to strengthening the defensive layers and identifying and mitigating latent conditions. By fixing the system, we can make it more resilient to the inevitability of human error. Human factors engineering is the applied science that puts the principles of systems thinking into practice. It is the discipline that systematically identifies the holes in the Swiss cheese and redesigns the slices to be stronger and more resilient. Human factors engineering has been a driving force behind major safety improvements in healthcare, most notably in the field of anesthesiology, where the redesign of anesthesia equipment and workflows led to a dramatic reduction in patient mortality. The application of human factors engineering in healthcare is broad and focuses on optimizing the interaction between clinicians, technology, and the work environment. Key applications include usability testing. Before new technology, such as an electronic health record or a new infusion pump, is deployed, human factors engineers conduct rigorous usability testing. They observe clinicians using the device in simulated real-world conditions to identify design flaws, confusing interfaces, or unintended consequences that could lead to errors. For example, a usability study might reveal that the display on a computerized provider order entry system makes it easy for a physician to accidentally select a tenfold overdose of a medication, a design flaw that can be corrected before it ever reaches a patient. Human factors engineering also focuses on identifying and addressing workarounds, the ways in which frontline staff bypass official procedures or safety features to get their work done efficiently. While often seen as violations, workarounds are frequently a symptom of a poorly designed system. For instance, if a barcode medication administration system frequently fails to scan IV bags, nurses may develop a workaround of administering the medication without scanning and documenting it later. A human factors engineering analysis would not blame the nurse, but would instead identify the faulty scanner or software as the latent condition that needs to be fixed. Human factors engineering principles are also used for system and process redesign to reduce the likelihood of error. This can range from standardizing the layout of an operating room to reduce the chance of grabbing the wrong instrument, to implementing checklists that ensure critical steps are not missed, to designing better alarms and alerts that reduce alarm fatigue among staff. The Agency for Healthcare Research and Quality actively funds numerous projects that apply human factors engineering to address a wide range of patient safety challenges, from improving diagnostic safety to making electronic health records safer and more effective. By systematically applying these principles, healthcare organizations can move beyond simply reacting to errors and begin proactively designing systems of care that are fundamentally safer. Now let's move into Section 2, which covers root cause analysis, the foundation of error investigation. As mandated by Florida law, a core competency for all healthcare professionals is an understanding of root cause analysis, commonly abbreviated as RCA. Root cause analysis is the primary methodology used in healthcare to investigate adverse events and near misses in a structured, systems-oriented way. It is the practical application of the principles discussed in the previous section, providing a formal process for looking beyond the active errors of individuals to uncover the latent conditions that truly caused an event. Root cause analysis is a retrospective, structured method used to analyze serious adverse events with the goal of answering three fundamental questions. What happened? Why did it happen? And how can we prevent it from happening again? The central tenet of root cause analysis is to identify the underlying problems within the system that increase the likelihood of errors, while deliberately avoiding the trap of focusing on individual blame. It is an interdisciplinary process that should involve experts from frontline services, those who are most familiar with the situation being investigated. The ultimate goal of a root cause analysis is not to produce a report, but to identify and implement meaningful changes to systems and processes that will prevent future harm. It is a foundational element in the effort to build a culture of safety and move beyond a culture of blame. While specific methodologies can vary, most effective root cause analyses follow a common sequence of steps, synthesizing best practices from organizations like the Department of Veterans Affairs, the Agency for Healthcare Research and Quality, and the Institute for Healthcare Improvement. The first step is to identify what happened. This involves chartering a multidisciplinary team and gathering data to reconstruct the event as accurately and completely as possible. This involves reviewing medical records, examining equipment, and conducting interviews with the individuals involved. A key tool in this phase is the creation of a detailed timeline or flowchart, which helps to visually map the sequence of events as they occurred. The second step is to determine what should have happened. The team then maps out the ideal process of care for this type of situation. By comparing the actual event timeline with the ideal process map, the team can clearly identify the deviations, gaps, and failures that occurred. The third step is to determine causes by asking why. This is the heart of the analysis. The team works to identify all the factors that contributed to the event. This includes the most apparent direct causes, often active errors, and the more subtle contributory factors, often latent conditions. The team must continually dig deeper by asking why at each level of cause and effect to move beyond the superficial and uncover the true systemic vulnerabilities. The fourth step is to develop causal statements. A causal statement is a structured sentence that links the identified cause to its effect on the outcome. A well-formed causal statement clearly shows the relationship between a root cause and the adverse event without resorting to blame. For example, instead of saying, "the nurse administered the wrong dose," a causal statement might say, "the lack of a standardized concentration for the medication in the automated dispensing cabinet, which is the cause, led the nurse to select the wrong vial, resulting in a 10-fold overdose, which is the effect." The fifth step is to generate and prioritize solutions. For each identified root cause, the team brainstorms potential interventions to eliminate or mitigate the vulnerability. It is critical in this step to focus on system-level changes rather than weaker actions aimed at individuals. The sixth step is to implement and measure. The team develops a detailed action plan, assigning responsibility and timelines for each recommended intervention. After implementation, the effectiveness of the changes must be measured to ensure they have had the desired impact on safety. To facilitate the analysis, root cause analysis teams often use specific structured tools to guide their brainstorming and investigation. One such tool is the 5 whys technique. This is a simple but surprisingly effective technique for drilling down from a problem symptom to its root cause. The team starts with the problem and repeatedly asks the question why, typically about 5 times, with each answer forming the basis for the next question. This iterative questioning helps to peel back the layers of an issue. Let me give you an example of how the 5 whys technique works. The problem is that a patient received the wrong medication. The first why asks, why did the patient receive the wrong medication? The answer is that the nurse did not complete patient identification. The second why asks, why did the nurse not complete patient identification? The answer is that the patient did not have a wristband. The third why asks, why did the patient not have a wristband? The answer is that the wristband had been removed for a procedure and not replaced. The fourth why asks, why was the wristband not replaced? The answer is that the printer for the wristbands was not working. The fifth why asks, why was the printer not working? The answer is that the printer was out of toner, and there was no process for checking toner levels or stocking replacements. This final answer represents the root cause. Another valuable tool is the Fishbone diagram, also known as the Ishikawa diagram or a cause and effect diagram. This is a visual tool used to explore and categorize the many potential causes of a problem. The problem or effect is written at the head of the fish. The main bones extending from the spine represent major causal categories, which in healthcare are often adapted to include people, meaning issues related to staff such as training, fatigue, or communication, policies and procedures, meaning problems with protocols, guidelines, or clinical pathways, equipment, meaning failures or design flaws in medical devices or technology, environment, meaning factors in the physical workspace such as lighting, noise, or layout, patients, meaning factors related to the patient's condition, characteristic. The team brainstorms potential causes within each category, allowing for a comprehensive, structured view of all contributing factors. Recognizing that many root cause analyses fail to produce meaningful, lasting change, the Institute for Healthcare Improvement has advanced the concept of root cause analyses and actions, abbreviated as RCA squared or RCA2. The addition of "and" actions is a deliberate emphasis that the ultimate goal of the process is not the analysis itself, but the implementation of strong, effective, and sustainable actions that will genuinely prevent future harm. A central component of the RCA2 framework is the action hierarchy. This tool provides a critical framework for evaluating and prioritizing the interventions brainstormed during the root cause analysis process. It helps teams move beyond weak, simplistic fixes and focus on more robust, reliable system redesigns. Many RCA investigations default to recommending weaker actions, such as retraining staff or writing a new policy, because they are easier to implement. However, these actions rely heavily on fallible human memory and vigilance and are unlikely to create sustained improvement on their own. The action hierarchy provides a clear, practical guide for identifying stronger solutions that are more resilient to human error. By using this tool, clinicians participating in a root cause analysis can critically assess proposed solutions and advocate for changes that will have a real and lasting impact on patient safety. Let me walk you through the action hierarchy for RCA2 recommendations, starting with the strongest actions and moving to the weakest. Stronger actions are at the top of the hierarchy. The first type is physical changes or forcing functions that make it impossible to do the wrong thing. A clinical example would be removing concentrated potassium chloride from all patient care unit floor stock. The second type of stronger action is architectural or engineering controls that change the physical environment. A clinical example would be designing patient rooms so the bed is visible from the nursing station. The third type of stronger action is automation or computerization that uses technology to reduce reliance on humans. A clinical example would be implementing a computerized physician order entry system with hard stop alerts for critical drug interactions. Intermediate actions are in the middle of the hierarchy. The first type is simplification and standardization. A clinical example would be standardizing to a single concentration for heparin infusions throughout the hospital. The second type of intermediate action is checklists, reminders, and redundancies. Clinical examples would be using a preoperative checklist or requiring an independent double check for insulin doses. The third type of intermediate action is increased staffing or reduced workload. A clinical example would be adjusting nurse-to-patient ratios to reduce fatigue and cognitive overload. Weaker actions are at the bottom of the hierarchy. The first type is rules, policies, and procedures. A clinical example would be writing a new policy that requires 2 nurses to sign off on high alert medications. The second type of weaker action is warnings and labels. A clinical example would be placing a high alert sticker on a medication bin. The third type of weaker action is education and training. A clinical example would be holding an in-service training session on the new medication administration policy. This hierarchy was adapted from the VA National Center for Patient Safety and the Institute for Healthcare Improvement RCA2 framework. Despite its widespread adoption and regulatory mandate, the root cause analysis process is not without its challenges and criticisms. To conduct a truly effective analysis, teams must be aware of and actively work to avoid several common pitfalls. One pitfall is the quest for a single root cause. The name root cause analysis can be misleading, as it implies that a single cause can be found for every adverse event. In reality, most incidents in complex systems like healthcare are the result of multiple interacting causes. An oversimplified analysis that identifies only one root cause risks missing other critical system vulnerabilities. Some experts have even suggested renaming the process systems analysis to better reflect this complexity. Another pitfall is the questionable quality of investigations. Root cause analyses are often conducted by local, ad hoc teams that may lack deep expertise in human factors, cognitive science, and formal accident investigation techniques. This can lead to superficial analyses that fail to uncover the true latent conditions. A third pitfall is what might be called political hijack. The root cause analysis process does not happen in a vacuum. It is often subject to significant time pressure from regulatory bodies, skewed by hindsight bias, which is the tendency to see the event as more predictable than it was, and influenced by internal organizational politics. These pressures can lead to a goal displacement, where the primary aim becomes completing the report on time rather than conducting a thorough and honest investigation. A fourth pitfall is weak recommendations. As previously discussed, a major failing of many root cause analyses is the tendency to produce weak, ineffective recommendations that focus on policies, procedures, and training. This is often the path of least resistance but does little to prevent recurrence. The rigorous application of a tool like the action hierarchy is essential to counteract this tendency. Now let's move into Section 3, which covers building a resilient culture of safety. While tools like root cause analysis are essential for reacting to and learning from errors, the ultimate goal of a patient safety program is to create an organization that is proactively and continuously resistant to failure. This requires building and sustaining a robust culture of safety. A safety culture is not something that can be achieved through a single initiative or policy. It is the product of shared beliefs, values, and behaviors that are embedded in every level of the organization. A culture of safety is the extent to which an organization's culture supports and promotes patient safety. It is the collective way things are done around here when it comes to safety. Organizations with a strong safety culture, often referred to as high-reliability organizations, share several key features. First, there is acknowledgement of high risk, meaning there is a shared understanding that the organization's activities are inherently complex and hazardous, which fosters a constant sense of vigilance. Second, there is a blame-free environment, meaning individuals feel safe reporting errors or near misses without fear of punishment or reprimand, which is essential for organizational learning. Third, there is encouragement of collaboration, meaning teamwork and open communication across ranks and disciplines are encouraged to find solutions to safety problems. Fourth, there is organizational commitment of resources, meaning leadership demonstrates that safety is a top priority by dedicating the necessary time, personnel, and financial resources to address safety concerns. Because culture can be an abstract concept, it is important to have standardized ways to measure it. The Agency for Healthcare Research and Quality has developed the Surveys on Patient Safety Culture Program, abbreviated as SOPs, to meet this need. These are a suite of validated survey instruments designed to assess the safety culture from the perspective of frontline providers and staff. There are specific versions of the SOP survey for different healthcare settings, including hospitals, medical offices, nursing homes, community pharmacies, and ambulatory surgery centers. These surveys measure key dimensions of safety culture, such as teamwork within units, supervisor and manager expectations and actions promoting safety, organizational learning and continuous improvement, management support for patient safety, communication openness, non-punitive response to error, and staffing. Organizations can use their SOPS results to identify areas of strength and weakness in their safety culture, track improvements over time, and benchmark their performance against a national database of other similar organizations. Importantly, research has shown that more positive SOP scores are significantly correlated with better patient outcomes, including lower rates of hospital-acquired pressure ulcers, falls, and surgical site infections. Now let's discuss the Just Culture framework, which balances accountability and system improvement. Early in the patient safety movement, the concept of a no blame culture was heavily promoted to encourage error reporting. However, this approach was sometimes criticized for failing to address the need for professional accountability. In response, the more nuanced concept of a just culture was developed to balance the twin needs for systems improvement and appropriate accountability. A just culture provides a framework for differentiating between three types of human behavior and responding to them in a fair and consistent manner. The first type of behavior is human error, which is an inadvertent action, slip, lapse, or mistake. For example, a nurse accidentally picks up the wrong syringe. The error is unintentional. The just culture response is to console the individual and look for ways to redesign the system to prevent the error from happening again, such as using different colored syringes or improving labeling. The second type of behavior is at-risk behavior, which is a behavioral choice that increases risk, where the risk is not recognized or is mistakenly believed to be justified. This often manifests as a shortcut. For example, a nurse skips the barcode scanning step just this once because the system is slow and the patient is in pain. The just culture response is to coach the individual, helping them to see the risk in their behavior. Crucially, the organization must also investigate why the at-risk behavior occurred. Was the shortcut taken because the correct process is inefficient, cumbersome, or unrealistic? The system must be improved to make the right way the easy way. The third type of behavior is reckless behavior, which is a conscious disregard of a substantial and unjustifiable risk. For example, a surgeon deliberately refuses to perform the mandatory preoperative timeout. The just culture response is that this is the only category where punitive action is appropriate. The individual has made a blameworthy choice and must be held accountable. In a just culture, the response to an event is predicated on the type of behavior involved, not on the severity of the outcome. This framework creates an atmosphere of trust, encouraging staff to report their own errors and system vulnerabilities, knowing that they will be treated fairly and that the focus will be on learning and improvement, except in cases of truly reckless behavior. A resilient culture of safety cannot be built from the bottom up alone. It requires visible, active, and unwavering commitment from organizational leadership. Leaders are responsible for setting the tone, establishing the vision, and allocating the resources necessary to make patient safety the organization's highest priority. Effective leadership in patient safety involves several key actions. Leaders must establish a vision by clearly and consistently communicating a vision for a safe, reliable, and patient-centric organization. Leaders must foster psychological safety by actively creating an environment where staff feel safe to speak up, report concerns, and admit mistakes without fear of blame or retaliation. This includes championing a just culture and taking a non-punitive approach to error reporting. Leaders must model professional behavior by personally modeling the behaviors they expect from others, including professionalism, respect, and a commitment to open communication. This also means having zero tolerance for intimidating or disruptive behaviors that undermine teamwork and safety. Leaders must provide resources by ensuring that frontline teams have the necessary staffing, equipment, training, and time to do their work safely and effectively. Leaders must engage with the frontline, and a powerful leadership tool is the practice of executive walk-rounds, where senior leaders regularly visit patient care units to talk directly with frontline staff about their safety concerns. This demonstrates leadership commitment, builds trust, and provides leaders with unfiltered insights into the real-world challenges of care delivery. While a just culture provides the organizational framework for responding to error, psychological safety is the lived, day-to-day experience of individuals and teams that determines whether that framework is effective. Psychological safety is the shared belief that the team is safe for interpersonal risk-taking. It is the feeling that one can speak up with ideas, questions, concerns, or mistakes without being punished or humiliated. The link between psychological safety and patient safety is direct and powerful. In a healthcare setting, a climate of psychological safety and openness has been shown to result in more error reporting. This may seem counterintuitive, but it is not because more errors are being made. It is because team members feel safe enough to report the errors and near misses that are already occurring, providing the organization with vital data for learning and improvement. Conversely, in a psychologically unsafe environment, the consequences can be severe. Staff may not feel supported to intervene or challenge a senior colleague, even when they see a potential breach in practice. They may be reluctant to report bad news or negative outcomes up the chain of command. This fear can lead to biased or suppressed reporting, where only positive results are shared and problems are hidden until they result in a catastrophic failure. Creating psychological safety is a primary responsibility of team leaders and managers. It is fostered through behaviors like showing gratitude, encouraging open dialogue, promoting autonomy, and treating all team members with respect. When psychological safety is present, teams are more likely to learn, innovate, and perform at their best, creating a powerful defense against medical errors. Now let's move into Section 4, which covers high reliability communication and teamwork. Many medical errors are not the result of a lack of clinical knowledge, but are instead caused by failures in teamwork and communication. In the fast paced, high stakes environment of healthcare, the ability of a multidisciplinary team to share information effectively, coordinate actions, and support one another is a critical patient safety defense. High reliability organizations actively cultivate these skills through structured training and the use of standardized communication tools. Team STEPS, which stands for Team Strategies and Tools to Enhance Performance and Patient Safety, is a premier evidence based teamwork system designed specifically for healthcare. Developed by the Agency for Healthcare Research and Quality in collaboration with the U.S. Department of Defense, the Team STEPS curriculum is based on more than 2 decades of research on high-performing teams in fields like aviation. The framework is built around 4 core teachable, learnable competencies. The first is communication, which is the process by which information is clearly and accurately exchanged among team members. Team STEPS provide specific tools to ensure that communication is structured and effective. The second is leading teams, which is the ability to coordinate the activities of team members by ensuring that team actions are understood, changes in information are shared, and team members have the necessary resources. Effective team leadership involves defining a clear plan, assigning roles and responsibilities, monitoring the plan, and modeling effective teamwork. The third is situation monitoring, which is a process of actively scanning and assessing situational elements to gain information, understanding, or maintain awareness of what is going on around you. This leads to a shared mental model, where all team members are on the same page regarding the patient status and the plan of care. The fourth is mutual support, which is the ability to anticipate and support other team members' needs through accurate knowledge about their responsibilities and workload. This includes providing and requesting assistance, as well as respectfully speaking up when a safety breach is observed. By training teams in these 4 core skills, organizations can significantly improve the quality of information exchange, enhance collaboration, reduce the potential for error, and build a culture of shared responsibility for patient safety. One of the most widely adopted and effective tools from the Team STEPS curriculum is SBAR, a structured framework for communication. SBAR was originally developed in the U.S. Navy for use on nuclear submarines and was later adapted for healthcare by Kaiser Permanente to improve the clarity and efficiency of communication between nurses and physicians. It provides a simple, memorable, and standardized format for conveying critical information, particularly during patient handoffs or when a change in the patient's condition requires urgent attention. SBAR stands for Situation, Background, Assessment, and Recommendation. Let me walk you through each component. S stands for Situation, which is a concise statement of the problem. What is going on with the patient right now? An example would be, Dr. Jones, this is Sarah, the nurse in room 312. I'm calling about Mr. Smith. He has become acutely short of breath. B stands for Background, which is brief, pertinent information related to the situation. What is the relevant clinical context? An example would be, he is a 68-year-old man who is post-op day 2 from a knee replacement. He has no prior history of cardiac or pulmonary disease. A stands for Assessment, which is what you think the problem is. What is your analysis of the situation? An example would be, his oxygen saturation has dropped to 88% on room air, his respiratory rate is 28, and he is tachycardic at 115. I am concerned he may be having a pulmonary embolism. R stands for Recommendation, which is what you want or what you recommend be done. What action is needed? An example would be, I recommend that you come see the patient immediately. In the meantime, should I start him on oxygen and order a stat spiral CT scan? The power of SBAR lies in its structure. It forces the sender to organize their thoughts before communicating, and it sets clear expectations for the receiver about the information they are about to hear. This reduces ambiguity, prevents vital information from being omitted, and allows for a clear and direct request for action. It is an essential tool for overcoming authority gradients and empowering all team members to speak up with concerns in a professional and effective manner. While verbal communication tools like SBAR are critical for real-time interactions, the patient's medical record is the primary tool for asynchronous communication among the care team. As such, clinical documentation is not merely a clerical or billing task, it is a high-leverage patient safety intervention. Poor documentation, that which is illegible, incomplete, inaccurate, or untimely, is a direct cause of communication failure and a significant latent threat to patient safety. The critical link between documentation and safety is evident in the work of the Agency for Healthcare Research and Quality. The entire suite of AHRQ quality indicators, including the patient safety indicators, are calculated using administrative data that is abstracted directly from clinical documentation and coding. If the documentation is inaccurate or incomplete, the resulting safety metrics will be flawed. This can either mask real safety problems, preventing the organization from learning and improving, or create the false appearance of problems, leading to wasted resources on unnecessary investigations. Therefore, every act of documentation is an act of patient safety. A clear, accurate, and timely note strengthens a critical defensive layer in the Swiss cheese model, while a poor note creates a dangerous hole. Best practices for safe clinical documentation include timeliness, meaning documenting care in real time or as close to it as possible, because delays in documentation can lead to other providers acting on outdated or incomplete information. Best practices also include clarity and completeness, meaning ensuring that notes are legible if handwritten, and use clear, unambiguous language, and that the clinical reasoning behind decisions should be articulated, not just the decisions themselves. Standardization is another best practice, meaning using standardized templates and terminology where appropriate to ensure that information is consistently captured and easy to find, including avoiding the use of unapproved or dangerous abbreviations, which are a common source of misinterpretation. Accuracy is essential, meaning verifying all information before it is entered into the record, including patient identifiers, allergies, and medication lists. Finally, closing the loop is critical, meaning documenting that test results have been reviewed and that follow-up actions have been taken, since a common source of diagnostic error is the failure to act on an abnormal test result that was never communicated back to the ordering provider. By treating clinical documentation with the same rigor and attention to detail as any other clinical intervention, healthcare professionals can significantly reduce the risk of communication-related medical errors. Now let's move into Section 5, which focuses specifically on medication and diagnostic errors. While the principles of systems thinking and safety culture apply to all aspects of healthcare, certain clinical processes are inherently higher risk and warrant a specialized focus. Medication administration and the diagnostic process are two areas where patients are particularly vulnerable to harm. This section will provide a detailed review of common error types and prevention strategies in these domains, including the specific areas of concern identified by Florida's boards of medicine and osteopathic medicine. Medication errors are one of the most common and preventable causes of patient harm. The World Health Organization reports that medication-related harm affects 1 out of every 30 patients in healthcare, and that half of all avoidable harm is related to medications. Errors can occur at any stage of the medication use process, which includes prescribing, transcribing, dispensing, administering, and monitoring. Common types of medication errors include administering the wrong drug, wrong dose, or wrong dosage form, administering a drug via the wrong route, errors of omission, meaning failing to administer a prescribed dose, administering a drug at the wrong time or at the incorrect rate, and administering a drug to a patient with a known allergy or contraindication. A comprehensive approach to medication safety involves implementing multiple, layered defenses to intercept errors before they can reach the patient. Key evidence-based prevention strategies include medication reconciliation, which is the formal process of creating the most accurate list possible of all medications a patient is taking, including prescription drugs, over-the-counter products, and herbal supplements, and comparing that list against the physician's admission, transfer, and discharge orders. This process is critical at every transition of care to prevent omissions, duplications, and dosing errors. Studies have shown that pharmacist-led medication reconciliation is particularly effective at reducing adverse drug events. The use of technology is another key strategy. Technology can be a powerful defense against medication errors when designed and implemented correctly. Key technologies include computerized physician order entry, or CPOE, which eliminates errors related to illegible handwriting and can be integrated with clinical decision support systems to provide real-time alerts for potential drug interactions, allergies, and incorrect dosages. Barcode medication administration, or BCMA, requires the nurse to scan a barcode on the patient's wristband and on the medication package before administration. And the system then verifies that it is the right patient, right drug, right dose, right route, and right time, providing a critical final safety check at the bedside. Smart infusion pumps contain a drug library with pre-programmed dose limits for high-risk medications, helping to prevent catastrophic overdose errors with intravenous infusions. Standardization and simplification is another strategy. Reducing unnecessary variation in the medication use process can significantly reduce the potential for error. This includes standardizing medication concentrations, using pre-mixed IV solutions, developing standard order sets for common conditions, and limiting the number of different drug formulations available on the formulary. Patient education and engagement is also essential. The patient is the final line of defense. It is crucial to educate patients and their families about their medications, including the name of each drug, its purpose, the dose, and potential side effects. Patients should be encouraged to ask questions and speak up if a medication looks different than usual or if they have any concerns. Now let's discuss managing high alert and look-alike, sound-alike medications. While all medication errors have the potential to cause harm, errors involving certain medications are much more likely to have devastating consequences. These are known as high alert medications. These are drugs that bear a heightened risk of causing significant patient harm when they are used in error. While mistakes with these drugs may not be more common, the outcome of an error is far more severe. The Institute for Safe Medication Practices maintains a list of high alert medications, which includes classes such as insulin, both subcutaneous and IV, anticoagulants such as heparin and warfarin, opioids via all routes, neuromuscular blocking agents such as succinylcholine, concentrated electrolytes such as potassium chloride for injection, and chemotherapeutic agents. Look-alike, sound-alike medications, commonly abbreviated as LASA medications, are another category of drugs that are particularly prone to error. These are drugs with names that look similar when written or sound similar when spoken, or whose packaging is confusingly similar. A classic example is the confusion between the vasopressor ephedrine and the cardiac stimulant epinephrine. Because of the significant risks associated with these medications, they require special safeguards. Best practices for managing high alert and LASA drugs include developing an organization-specific list, where each organization should develop its own list of high alert and LASA medications based on its unique formulary and internal error data. Physical segregation and labeling is also important, meaning storing high alert and LASA drugs in separate, clearly labeled bins, avoiding storing them in alphabetical order if that places two LASA drugs next to each other, and using prominent, standardized warning labels on storage bins, shelves, and the medications themselves. Tall man lettering is another strategy, which uses a mix of upper and lowercase letters to help differentiate LASA drug names on labels and computer screens, such as hydroxyzine versus hydralazine. Limiting access is another best practice, which means restricting access to certain high alert medications, such as removing concentrated electrolytes from all patient care unit floor stock and keeping them only in the pharmacy. Independent double checks are also recommended, requiring that another qualified healthcare professional independently verify the drug, dose, and pump settings before the administration of certain high-risk medications. Finally, technology should be maximized, such as requiring a barcode scan to verify the drug before it is removed from an automated dispensing cabinet and again at the bedside before administration. Now let's focus specifically on Florida's most misdiagnosed conditions. As required by Florida Statute 456.13, this course must address the 5 most misdiagnosed conditions as determined by the Florida Board of Medicine and the Florida Board of Osteopathic Medicine. These lists are based on a review of disciplinary cases and highlight the areas of practice that pose the greatest risk to patients and practitioners in the state. The lists are updated periodically and reflect the specific concerns of each board. Let's first discuss the Florida Board of Medicine's 5 most misdiagnosed conditions. As of early 2024, the Florida Board of Medicine has identified the following 5 areas as the most frequently misdiagnosed conditions leading to quality of care violations. These are oncology-related conditions, gastroenterology-related conditions, cardiology-related conditions, neurological conditions, and infectious disease-related conditions. Regarding oncology-related conditions, delayed or misdiagnosis of cancer is a leading cause of medical malpractice claims and significant patient harm. An estimated 12% of cancer patients are initially misdiagnosed. Common pitfalls include failing to follow up on abnormal test results or incidental findings on imaging studies, and dismissing symptoms in patients who do not fit the typical demographic profile for a specific cancer, such as a young person with symptoms of colon cancer. The most frequently diagnosed cancers in Florida, such as lung, breast, prostate, and colorectal cancer, are also among the most commonly misdiagnosed. Prevention requires adherence to screening guidelines, diligent follow-up on all tests, and maintaining a high index of suspicion for cancer even in ambiguous cases. Regarding gastroenterology-related conditions, many gastrointestinal conditions present with nonspecific complaints like abdominal pain, nausea, or changes in bowel habits, which can complicate and delay diagnosis. This can lead to serious consequences, as seen in cases where pancreatic cancer, which has a poor prognosis if not caught early, is initially misdiagnosed as more benign conditions like gallbladder disease. The diagnosis of functional GI disorders such as irritable bowel syndrome can be particularly challenging and may be incorrectly dismissed as psychological in nature. Regarding cardiology-related conditions, misdiagnosis of acute cardiovascular events remains a critical problem. Heart attacks, particularly in women who may not present with classic crushing chest pain, are frequently missed. Other life-threatening vascular events like pulmonary embolism, stroke, and aortic dissection are also commonly misdiagnosed, often because their symptoms can mimic other conditions. A delay in diagnosing these conditions can be the difference between life and death or permanent disability. Regarding neurological conditions, this category often overlaps with cardiology, with stroke being a major area of concern. Failure to recognize the signs and symptoms of a transient ischemic attack or an acute stroke can lead to a missed opportunity for time-sensitive interventions like thrombolysis, which can dramatically improve outcomes. Another critical and often missed neurological emergency is cauda equina syndrome, a form of spinal cord compression that can lead to irreversible paralysis if not diagnosed and treated emergently. Regarding infectious disease-related conditions, the failure to timely diagnose and treat serious infections, particularly sepsis, is a major patient safety concern. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. Early recognition and initiation of protocol-based care, such as fluids and antibiotics, are critical to survival. Diagnostic errors often involve failing to recognize the subtle early signs of sepsis or misattributing them to other conditions, leading to critical delays in treatment. Now let's discuss the Florida Board of Osteopathic Medicine's 5 most misdiagnosed conditions. The Florida Board of Osteopathic Medicine's list has some overlap with the Board of Medicine's list, but also reflects a distinct focus on issues related to prescribing practices and surgical care. The 5 conditions are inappropriate prescribing of controlled substances, failure or delay in diagnosing cancer, retained foreign objects in surgery and wrong site or wrong patient surgery, surgical complications and errors and preoperative evaluations, and failure to timely diagnose sepsis. Regarding inappropriate prescribing of controlled substances, this reflects the intense regulatory focus on the opioid crisis. Disciplinary actions in this category often stem from the failure to properly diagnose and manage underlying conditions, such as addiction, substance use disorder, psychiatric conditions, or drug diversion in patients being prescribed opioids or other controlled substances. It also includes the failure to adequately monitor the safety and efficacy of these prescribed medications. Regarding failure or delay in diagnosing cancer, this concern is shared with the Board of Medicine and underscores the universal importance of timely and accurate cancer diagnosis across all medical specialties. Regarding surgical errors, including retained foreign objects and wrong site or wrong patient surgery, these are considered never events, errors so serious they should never happen. Prevention relies on the rigorous and consistent application of safety protocols such as the surgical timeout, which is a final verification of the correct patient, procedure, and site before incision, meticulous instrument and sponge counts, and robust patient identification procedures using at least two unique identifiers. Regarding surgical complications and errors and preoperative evaluations, this category encompasses a broader range of surgical care issues, including inadequate preoperative assessment of patient risk, failure to obtain proper informed consent, technical errors during a procedure, and failure to timely recognize and respond to postoperative complications like bleeding or infection. Regarding failure to timely diagnose sepsis, this is a more recent addition to the board's list, reflecting a growing national awareness of the high mortality associated with delayed sepsis diagnosis and treatment. This aligns with the Board of Medicine's focus on infectious diseases and highlights the critical need for all physicians to be vigilant for the signs of sepsis. Now let's move into Section 6, which covers reporting, disclosure, and professional responsibility. A comprehensive approach to patient safety extends beyond prevention. It must also include a clear and ethical framework for how to respond when an error does occur. This involves the professional's ethical duty to be transparent with patients, the organization's responsibility to learn from errors through robust reporting systems, and an understanding of the state's regulatory and disciplinary processes. When a medical error results in harm to a patient, healthcare professionals have a profound ethical and professional obligation to disclose the event to the patient and their family. This duty is rooted in fundamental ethical principles. Respect for patient autonomy and veracity means patients have a right to know what has happened to them and to make informed decisions about their subsequent care. Truthfulness is essential to honoring this autonomy. Fidelity and trust means the provider-patient relationship is built on a foundation of trust and a fiduciary responsibility to act in the patient's best interest. Concealing an error is a betrayal of that trust. Beneficence and non-maleficence means the principles of doing good and avoiding harm are violated when errors are not disclosed. Disclosure allows for immediate action to mitigate the harm and prevent further injury. While clinicians and administrators often fear that disclosure will lead to anger and litigation, evidence suggests the opposite may be true. Candid, empathetic, and timely disclosure, including an apology and an explanation of what will be done to prevent recurrence, can often preserve the patient's trust and may even reduce the likelihood of a lawsuit. Patients are often more angered by the perceived cover-up than by the initial error itself. Disclosure is not just an ethical imperative, it is a critical component of maintaining a therapeutic relationship and demonstrating respect for the patient as a person. Internal patient safety event reporting systems, often called incident reporting systems, are a ubiquitous feature of modern hospitals and a primary mechanism for identifying safety hazards. The purpose of these systems is to collect data on adverse events, near misses, and unsafe conditions directly from frontline staff who are in the best position to observe them. This data can then be analyzed to identify trends and system vulnerabilities, providing the basis for targeted improvement efforts. For an event reporting system to be effective, it must possess several key attributes. It must exist within a supportive, non-punitive environment that protects the confidentiality of reporters. It must be accessible and easy to use for a broad range of personnel. It must provide timely feedback to those who report so they know their concerns have been heard and acted upon. And there must be a structured mechanism for reviewing reports and developing and tracking action plans. However, it is crucial to understand the limitations of these systems. Because reporting is voluntary, these systems are a form of passive surveillance and are subject to significant selection bias. They capture only a small fraction of the total number of safety events that occur and may not reliably identify the most serious events. Therefore, data from event reporting systems should be used to highlight specific areas for deeper investigation, not as a comprehensive measure of the overall safety of the organization. To facilitate learning across institutions, the Agency for Healthcare Research and Quality has developed common formats, which are standardized definitions and reporting formats for a wide range of patient safety events. The adoption of these formats allows for the aggregation and comparison of safety data, helping to identify national trends and best practices. When a patient safety event rises to the level of a potential violation of the Professional Practice Act, it may become the subject of a complaint to the Florida Department of Health. All licensed healthcare professionals in Florida should have a basic understanding of this regulatory process. Complaints against a licensed practitioner or facility can be filed by patients, family members, or other concerned parties through the Florida Healthcare Complaint Portal. The Department of Health's Consumer Services Unit reviews each complaint to determine if it is legally sufficient, that is, if it alleges a potential violation of a Florida statute or rule governing that profession. If a complaint is deemed legally sufficient, it is referred to the Prosecution Services Unit and an investigation is opened. The investigation may involve reviewing medical records, interviewing the practitioner and witnesses, and obtaining expert opinions. It is important to note that by law, a complaint remains confidential until 10 days after a determination of probable cause is made. Following the investigation, a probable cause panel, typically composed of members of the practitioner's professional board, reviews the findings. If the panel finds that probable cause exists to believe a violation occurred, a formal administrative complaint is filed and the case becomes public. The practitioner then has the opportunity to resolve the case through a settlement agreement or to contest the charges at a formal hearing. If a violation is ultimately found, the relevant board can impose a range of disciplinary penalties, including fines, reprimands, required continuing education, practice restrictions, probation, suspension, or in the most serious cases, revocation of the practitioner's license. The Department of Health's role in this process is purely administrative and regulatory. It does not represent the complainant in any civil matters or assist in recovering monetary damages. Now let's move into Section 7, which presents clinical case studies in medical error prevention. The following case studies are designed to illustrate how the principles discussed in this course apply to real-world clinical situations. By analyzing these scenarios, we can see how multiple system failures often combine to cause patient harm and identify stronger, more effective strategies for prevention. Let's begin with case study 1, the insulin overdose, a cascade of system failures. In this scenario, Mr. Davis, a 65-year-old patient with type 2 diabetes, is recovering on a busy surgical unit after a hip replacement. His post-operative blood glucose is elevated, and the physician orders 5 units of regular insulin to be given subcutaneously. The nurse, who is covering for a colleague on break and is now responsible for an unusually high number of patients, goes to the medication room. While preparing the injection, she is interrupted by a physician asking for an update on another patient. After the conversation, she returns to the medication cart, grabs a vial of U100 insulin from the refrigerated drawer, draws up 5 units, and administers it to Mr. Davis. An hour later, Mr. Davis is found unresponsive. A stat blood glucose check reveals he is severely hypoglycemic. It is discovered that the nurse inadvertently grabbed a vial of Humalog, a rapid-acting insulin analog, instead of regular insulin. The 2 vials have similar packaging and were stored next to each other in the same drawer. The hospital's barcode medication administration system was not used because the scanner in that room had been malfunctioning for a week. The error in this case was that a patient received the wrong type of insulin, leading to a severe hypoglycemic event. This is a classic medication error involving a high alert medication. Let's analyze this case using the course concepts we've discussed. This case is a perfect illustration of the Swiss cheese model. Multiple holes in the hospital's defenses align to allow the error to reach the patient. The active failure was that the nurse administered the wrong type of insulin. This is the sharp end error that is most visible. But there were multiple latent conditions, the blunt end system flaws that set the stage for the active failure. First, there were look-alike, sound-alike issues. The packaging of the 2 different insulin types was confusingly similar. Second, there were unsafe storage practices. 2 different types of insulin, one of which is a high alert medication, were stored together, increasing the risk of a selection error. Third, there was technology failure. The barcode medication administration system, a key safety barrier, was non-functional, and the failure to repair it in a timely manner was a significant latent error. Fourth, there were human factors issues. The nurse was experiencing a high cognitive load due to understaffing and was interrupted during a critical task, medication preparation, which is a known contributor to error. A 5 whys analysis of this case might look like this. Why did Mr. Davis become hypoglycemic? He received rapid-acting Humalog instead of regular insulin. Why did he receive the wrong insulin? The nurse picked the wrong vial. Why did she pick the wrong vial? The vials looked similar and were stored together, and she was distracted. Why wasn't the error caught before administration? The barcode scanner that would have alerted her to the mismatch was broken. Why was a key safety device allowed to remain broken for a week? There was no clear process for urgent repair of safety critical equipment, and leadership had not prioritized the resource allocation for it. Now let's consider prevention strategies using the action hierarchy. A weaker action would be to retrain the nurse on the 5 rights of medication administration. This fails to address any of the system issues. An intermediate action would be to implement a policy requiring an independent double check for all insulin doses and to standardize the storage of high alert medications, separating different types of insulin. Stronger actions would be to fix the barcode medication administration system and ensure 100% compliance, which is automation or computerization, and to work with the pharmacy to switch to insulin products with distinct packaging or use tall man lettering and warning labels on all insulin storage bins, which are engineering controls. Now let's move to case study 2, the missed sepsis diagnosis, a failure to communicate. In this scenario, Mrs. Chen, an 82-year-old woman from a nursing home, is brought to the emergency department with confusion, weakness, and a low-grade fever. The ED physician, Dr. Evans, suspects a urinary tract infection, a common cause of these symptoms in the elderly. He orders a urinalysis, a complete blood count, and a basic metabolic panel, including a lactate level. He starts her on IV fluids and a broad-spectrum antibiotic. The initial lab results come back, showing an elevated white blood cell count. The lactate level, a key indicator of sepsis, is critically high at 4.5 millimoles per liter. This result is posted to the electronic health record but does not trigger a hard stop or a mandatory notification to the physician. At the end of his shift, Dr. Evans hands off his patients to the incoming physician, Dr. Lee. The verbal handoff is brief and focuses on the working diagnosis. Room 5 is an 82-year-old from a nursing home with a likely UTI. Labs are pending. She's on fluids and Zosyn. The critical lactate value is not mentioned. Dr. Lee, now managing a full ED, continues with the plan for a UTI. 3 hours later, a nurse finds Mrs. Chen hypotensive and tachycardic. She is now in septic shock. The error in this case was failure to timely diagnose and treat sepsis, one of the most misdiagnosed conditions identified by both the Florida Board of Medicine and the Florida Board of Osteopathic Medicine. Let's analyze this case using our course concepts. This case highlights failures in diagnosis, communication, and technology design. There was a diagnostic error. The initial focus on a UTI led to anchoring bias, a cognitive error where the first impression is overweighted, and other possibilities like sepsis are not fully considered despite conflicting data. There was a communication failure. The handoff between Dr. Evans and Dr. Lee was unstructured and incomplete. It lacked the critical components of an SBAR communication. The situation was incomplete, stating 82-year-old with likely UTI, but missing the signs of deterioration. The background was not fully conveyed. The assessment was missing the critical lactate level, so Dr. Lee did not have an accurate assessment. The recommendation was based on incomplete information. There was also a system and technology failure. The electronic health record failed to effectively communicate a life-threatening lab result. A passive posting of a critical value is not a reliable safety defense. There was a documentation failure. While the lab result was in the chart, it was not effectively closed loop. There was no documentation to confirm the ordering physician had seen and acted upon the critical value. Now let's consider prevention strategies using the action hierarchy. A weaker action would be to send an email reminding physicians to check all lab results before the end of their shift. An intermediate action would be to mandate the use of a structured handoff tool like SBAR for all patient transfers between providers, and to implement a policy requiring the lab to verbally call the ordering provider for all critical lactate values. Stronger actions would be to reconfigure the electronic health record to create a hard stop alert for critical lab values that cannot be bypassed until the physician acknowledges the result and documents a plan, which is automation with a forcing function, and to implement an automated sepsis screening tool in the EHR that flags at-risk patients based on vital signs and lab data. Now let's move to case study 3, the wrong site surgery, a breakdown in teamwork. In this scenario, a 45-year-old patient is scheduled for an arthroscopy of his left knee. In the preoperative holding area, a nurse asks him to confirm the procedure, and he correctly states, "Surgery on my left knee." The surgeon, Dr. Smith, arrives late and is in a hurry. He briefly greets the patient and signs the consent form without verbally confirming the site with the patient again. He marks the correct leg with his initials. In the operating room, the patient is positioned and draped. The surgical timeout is initiated by the circulating nurse. She reads from the chart. Patient is here for a knee arthroscopy. The surgeon and anesthesiologist murmur their agreement while continuing with other tasks. The specific site, left, is not verbally stated by the entire team. A junior nurse in the room notices that the surgical equipment is positioned for operating on the right knee but is hesitant to speak up, assuming the experienced surgeon knows what he is doing. Dr. Smith makes the incision on the right knee. The error is not discovered until the procedure is complete. The error in this case was wrong site surgery, a never event and one of the top issues cited by the Florida Board of Osteopathic Medicine. Let's analyze this case using our course concepts. This catastrophic error resulted from a complete breakdown of teamwork and safety protocols. There was a failure of team steps principles. In terms of leadership, the surgeon failed to set a tone of safety and instead modeled rushed, unsafe behavior. In terms of situation monitoring, the team failed to maintain a shared mental model. The surgeon was focused on the right knee, while the junior nurse was aware of a discrepancy but did not voice it. In terms of mutual support, the team failed to support each other. The junior nurse did not feel empowered to challenge the surgeon, and the rest of the team did not cross-monitor each other's actions. There was an ineffective timeout. The timeout was treated as a bureaucratic checkbox rather than a critical safety step. It was incomplete, lacking site specificity, and lacked the active engagement of all team members. There was a lack of psychological safety. The junior nurse's hesitation to speak up is a classic sign of a poor safety culture and a steep authority gradient. She did not feel psychologically safe to question a senior surgeon, fearing reprimand or humiliation. Now let's consider prevention strategies using the action hierarchy. A weaker action would be to counsel the surgeon and retrain the operating room team on the timeout policy. An intermediate action would be to implement a detailed, standardized timeout checklist that requires each team member to verbally confirm the patient, procedure, and site, and to conduct regular teamwork training using team steps to empower all staff to stop the line if they have a safety concern. A stronger action would be to implement a forcing function, where the surgical site marking is not just initials, but a large, unambiguous YES that is visible even after the patient is draped, and the procedure cannot begin until all team members can visualize and agree on the mark. Now let's discuss Case Study 4, a patient fall sentinel event with hip fracture. In this scenario, Mrs. Dorothy Chen, an 81-year-old retired librarian, was admitted to Palm Harbor Medical Center for treatment of community-acquired pneumonia. Her medical history included mild dementia, osteoporosis, hypertension, and hypothyroidism. She lived independently with her daughter, checking on her daily, and had no history of falls in the past year. Upon admission, Mrs. Chen's Morse Fall Scale score was calculated at 65, which is high risk, primarily due to her age, history of dementia, use of multiple medications including a diuretic, and general weakness from her acute illness. Per hospital protocol, she was placed on fall precautions including bed alarm activation, non-skid socks, call light within reach, and frequent toileting assistance. On the third night of her admission, Mrs. Chen was receiving IV antibiotics and was demonstrating improvement in her respiratory status. However, she had become increasingly confused during the evening hours, a pattern consistent with sundowning that is common in patients with dementia. Her daughter had left for the evening at 8 p.m. after assisting with dinner. At 11:15 p.m., the nursing assistant, Teresa Rodriguez, made her scheduled rounds and found Mrs. Chen sleeping peacefully. She documented that the bed alarm was activated and the bed was in the lowest position. At 11:45 p.m., while Ms. Rodriguez was assisting another patient with toileting, the unit secretary heard a bed alarm sounding from Mrs. Chen's room. The night shift nurse, Patricia Williams, was in the medication room preparing IV antibiotics for another patient. She heard the alarm but assumed the nursing assistant would respond. Ms. Rodriguez, still occupied with the other patient, did not hear the alarm. The unit secretary, unsure of the protocol, silenced the alarm from the central station and did not immediately notify nursing staff. 4 minutes after the alarm first sounded, Ms. Rodriguez returned to the hallway and heard the alarm reactivate. She went to Mrs. Chen's room and found the patient on the floor beside her bed, conscious but in obvious pain, clutching her right hip. Mrs. Chen stated she had needed to use the bathroom and forgot I wasn't supposed to get up by myself. X-rays revealed a displaced intertrochanteric fracture of the right hip. Mrs. Chen required surgical repair with a dynamic hip screw, followed by a prolonged recovery period. Her hospitalization extended from the originally anticipated 4 days to 16 days, and she was ultimately discharged to a skilled nursing facility for rehabilitation rather than returning home as planned. 6 months later, she had not regained her previous level of independence and continued to require assistance with daily activities. The error in this case was a preventable patient fall resulting in serious injury, a hip fracture, qualifying as a sentinel event reported to the Joint Commission. Let's analyze this case using our course concepts. This case demonstrates how technology limitations, unclear role assignments, and staffing challenges can combine to defeat fall prevention strategies. Looking at technology and equipment factors, the bed alarm could be silenced from central station without direct patient visualization. There was no escalation notification when the alarm was silenced remotely, and the alarm sound was similar to other unit alarms, reducing urgency perception. Looking at process and protocol factors, there was no clear assignment of who should respond to bed alarms. The unit secretary's role in alarm response was not defined in protocol. Fall risk reassessment was not performed after evening confusion was noted, and the toileting schedule was not adjusted for the patient's nighttime confusion pattern. Looking at staffing and workload factors, night shift staffing was at minimum level with 1 RN and 1 CNA for 12 patients. There were multiple high-fall risk patients on the unit with competing demands, and the CNA was caring for 12 patients, exceeding the recommended ratio of 1:8. Looking at patient-specific factors, sundowning behavior was increasing fall risk during evening and night hours. Diuretic medication was increasing toileting frequency, and osteoporosis was increasing fracture risk from any fall. Now let's consider prevention strategies using the action hierarchy. Weaker actions would include conducting fall prevention training for all unit staff, including unit secretaries, implementing post-fall huddles within 1 hour of any fall event, and establishing monthly fall prevention rounds with physical therapy and nursing leadership. Intermediate actions would include establishing a dedicated fall prevention technician role for night shift to provide continuous observation of highest risk patients, implementing a proactive toileting protocol with scheduled rounds every 2 hours for high fall risk patients, creating a visual alert system with colored door markers indicating fall risk level, and requiring pharmacist review of medications that increase fall risk with recommendation for timing adjustments. Stronger actions would include replacing the bed alarm system with direct-to-caregiver notification via mobile devices, eliminating central station silencing capability, implementing sensor flooring around beds of high-fall risk patients that alerts nursing staff when patients' feet touch the floor, and creating an automated EHR trigger for fall risk reassessment when confusion or delirium is documented. Now let's discuss Case Study 5, a look-alike, sound-alike drug error with tranexamic acid wrong route administration. In this scenario, Mrs. Maria Santos, a healthy 32-year-old prima gravida, was admitted to Bay Regional Medical Center's labor and delivery unit for a planned cesarean section due to breech presentation. Her pregnancy had been uncomplicated, and she had no significant medical history. The procedure was scheduled as the second case of the morning with an experienced obstetric team. The anesthesia plan included spinal anesthesia with 0.75% bupivacaine. The anesthesiologist, Dr. Elizabeth Harper, had performed thousands of spinal anesthetics during her career and had an excellent safety record. The operating room was well staffed with an experienced circulating nurse and scrub technician. On the medication preparation table in the operating room, several medications had been drawn up in advance for the case, including the spinal anesthetic bupivacaine, prophylactic antibiotics cefazolin, oxytocin for uterine contraction, and tranexamic acid, commonly called TXA, which had recently been added to the hospital's cesarean section protocol based on evidence showing reduced postpartum hemorrhage. The tranexamic acid vials were stored in the same medication cabinet as the local anesthetics. At 8:30 a.m., Dr. Harper prepared to administer the spinal anesthetic. She reached for the syringe labeled bupivacaine 0.75% that had been prepared by the anesthesia technician. However, the syringe she picked up actually contained tranexamic acid, a medication that, when given intrathecally into the spinal canal, causes severe neurological injury. The syringes were similar in size at 3 ml, and the medications were both clear, colorless liquids. The anesthesia technician had inadvertently drawn up the TXA into a syringe intended for the bupivacaine, confusing the similar-appearing 10 millivials. The vials had similar blue caps and labeling designs from the same manufacturer, differing only in the drug name printed on them. The technician was working quickly to prepare medications for multiple cases scheduled that morning. Dr. Harper performed the lumbar puncture and injected the contents of the syringe into the intrathecal space. Within seconds, Mrs. Santos reported severe burning pain radiating down both legs and screamed that something is very wrong. She rapidly developed tonic-clonic seizures and cardiovascular instability. The team immediately recognized that a wrong drug administration had occurred. Emergency cesarean delivery was performed under general anesthesia to deliver a healthy baby boy. However, Mrs. Santos developed status epilepticus requiring prolonged sedation and mechanical ventilation in the ICU. Despite aggressive treatment, including cerebrospinal fluid lavage and supportive care, Mrs. Santos survived but was left with permanent paraplegia from spinal cord injury. She remained hospitalized for 63 days and required transfer to a rehabilitation facility. 2 years later, she remains wheelchair-bound with incomplete return of bladder and bowel function. The error in this case was wrong route administration of tranexamic acid intrathecally instead of the intended spinal anesthetic, resulting in catastrophic and permanent neurological injury. This represents a never event involving a look-alike, sound-alike medication error with a high alert medication. Let's analyze this case using our course concepts. This catastrophic event illustrates how system design failures can lead to devastating outcomes despite experienced clinicians. Looking at human factors analysis, there were unsafe acts as the technician drew the wrong medication and the anesthesiologist did not verify syringe contents against the vial before injection. There were preconditions, including similar packaging, time pressure, multiple cases running simultaneously, and medications prepared in advance. There was inadequate supervision with no requirement for independent verification of spinal medication preparation. And there were organizational factors including TXA storage location adjacent to local anesthetics and no LASA precautions implemented when TXA was added to the protocol. Looking at look-alike factors, the TXA vials and local anesthetic vials were from the same manufacturer with identical blue cap colors. There was similar label design and placement of drug name. Both medications were clear, colorless liquids, and identical syringe size was used for both medications. Looking at process failures, TXA was stored in the same location as neuraxial medications. Batch preparation of medications was done in advance without labeling immediately upon draw. There was no barcode verification for medications administered in the OR. There was no independent double-check requirement for neuraxial medications, and the anesthesiologist did not verify syringe contents against the original vial before injection. Looking at organizational factors, the TXA protocol was implemented without medication safety review for LASA risks. No safety alert was distributed to anesthesia staff about TXA wrong route risk, and ISMP guidelines regarding TXA separation from neuraxial medications were not followed. Now let's consider prevention strategies using the action hierarchy. Weaker actions would include distributing the ISMP alert on TXA wrong route errors to all anesthesia and nursing staff, conducting simulation training on LASA medication error recognition and response, and establishing a policy requiring medication safety review before adding any new high-risk medication to protocols. Intermediate actions would include requiring independent double-check with 2 clinicians for all neuraxial medication preparation, mandating that the original vial be kept with the syringe until immediately before administration, and implementing a timeout specifically for neuraxial medication administration with verbal confirmation of drug name. Stronger actions would include removing all TXA vials from areas where neuraxial medications are stored so that TXA is now available only as pre-mixed IV bags from pharmacy, implementing point-of-care barcode verification for all operating room medications including neuraxial agents, procuring bupivacaine and other spinal agents in distinctive pre-filled syringes from the manufacturer, and applying bright orange 4 IV USE only labels to all TXA containers. Now let's discuss Case Study 6, which involves Florida reporting compliance through a multi-incident analysis. In this scenario, Sunshine Regional Medical Center, a 285-bed community hospital in Central Florida, experienced 3 significant patient safety events within a 2-week period. The hospital's new risk manager, Jennifer Collins, had been in her position for only 3 months when these events occurred. Her predecessor had retired, and there had been a gap in risk management oversight during the transition. The first event was a surgical site nerve injury. A 45-year-old patient underwent laparoscopic cholecystectomy for gallstones. During the procedure, the common bile duct was inadvertently injured, and the patient also sustained a brachial plexus injury from positioning during the prolonged procedure. The bile duct injury required surgical repair, and the patient was discharged with persistent numbness and weakness in the right arm. The brachial plexus injury was documented as limitation of neurological function continuing after discharge. The second event was a retained surgical sponge. A 62-year-old patient who had undergone abdominal surgery 2 weeks earlier presented to the ED with fever, abdominal pain, and elevated white blood cell count. CT scan revealed a retained surgical sponge from her previous procedure. She required reoperation to remove the foreign body and treat the resulting abscess. The third event was a patient death following a medication error. A 78-year-old patient admitted for heart failure management received a 10-fold overdose of digoxin due to a decimal point error in the order. The patient developed fatal arrhythmia and died despite resuscitative efforts. The pharmacy had dispensed the incorrect dose, and nursing had administered it as dispensed. Let's analyze the reporting obligations for each event. Regarding Event 1, the nerve injury under Florida Statute 395.0197, this event meets the definition of an adverse incident because the brachial plexus injury constitutes limitation of neurological, physical, or sensory function which continues after discharge. The bile duct injury, while serious, was a recognized complication of the procedure and was repaired during surgery. However, the positioning-related nerve injury represents an event over which healthcare personnel could exercise control. The required action was to report to AHCA within 15 calendar days using the AHCA Incident Reporting System. Regarding Event 2, the retained sponge, this event clearly meets the statutory definition as any unplanned foreign objects remaining from a surgical procedure. Retained surgical items are specifically enumerated as reportable adverse incidents. This is also a serious reportable event or never event, according to the National Quality Forum, and would likely trigger Joint Commission Sentinel Event Review. Required actions were to report to AHCA within 15 days, conduct an RCA within 45 days per Joint Commission requirements, and notify the patient, which had already occurred when she presented with complications. Regarding Event 3, the patient death resulting from medication error unquestionably meets the adverse incident definition. The death resulted from medical intervention, the administration of digoxin, rather than the patient's underlying condition of heart failure. Multiple healthcare personnel, including the physician, pharmacist, and nurse, had opportunities to prevent this error. Required actions were to report to AHCA within 15 days, report to Joint Commission as a sentinel event, notify the family as a disclosure obligation, coordinate with risk management regarding potential litigation, and review with pharmacy and nursing leadership. The risk manager faced immediate challenges in managing these events according to Florida's adverse incident reporting requirements. She needed to determine which events met the statutory definition of an adverse incident under Florida Statute 395.0197, ensure timely reporting within the 15 calendar day deadline known as Code 15, coordinate notification to patients and families as required, initiate appropriate internal investigations, and prepare for potential regulatory scrutiny. Additionally, she discovered that the hospital's internal incident reporting system had not been properly maintained, with several incident reports from the past 6 months lacking complete documentation. The hospital had also failed to submit its annual report to the Agency for Healthcare Administration summarizing adverse incidents and malpractice claims information for the previous year. This case study illustrates several key takeaways. Florida Code 15 reporting requires submission within 15 calendar days, and this deadline is absolute. Failure to comply can result in significant penalties. Risk manager transitions create vulnerability, so succession planning and coverage arrangements are essential. Multiple adverse events in a short period may indicate systemic safety culture issues requiring organizational attention. In applying just culture principles to evaluate the involved staff's actions, the analysis determined that the surgical team's positioning error represented at-risk behavior with insufficient attention to positioning during a prolonged case, warranting coaching rather than discipline. The retained sponge represented human error compounded by system failure with inadequate count protocol compliance, indicating a need for consoling the individual and focusing on system improvement. The medication error chain involved multiple human errors by the prescriber, pharmacist, and nurse, each requiring individual evaluation but primarily system-focused interventions. The risk manager implemented several corrective actions and system improvements. In terms of risk management infrastructure, she implemented a new electronic incident reporting system with automatic escalation pathways, established weekly risk management committee meetings with the CNO, CMO, and department heads, created a position for assistant risk manager to ensure coverage during transitions, and developed an AHCA reporting deadline tracking system with automated reminders. For event-specific improvements, she implemented a mandatory position assessment protocol every 30 minutes during prolonged surgical cases, added RFID surgical sponge tracking technology with a hard stop requiring reconciliation before closure, and implemented clinical decision support requiring pharmacist verification for all high-alert medication orders with maximum dose alerts. For staff education, she conducted hospital-wide training on Florida adverse incident reporting requirements, developed a competency module on internal incident reporting expectations, and provided just culture training for all managers and supervisors. The risk manager took several immediate actions in implementing Florida reporting requirements. She registered all 3 incidents in AHCA's incident reporting system within 48 hours of discovery. She notified hospital administration and the board of directors of the cluster of serious events. She initiated the patient notification process as required by Florida Statute 395.0197, ensuring affected patients and families were informed as soon as practicable. She sequestered relevant medical records and equipment pending investigation, and she assembled RCA teams for each event with appropriate subject matter experts. For each adverse incident report submitted through the AHCA system, the risk manager ensured the following elements were included: patient demographics that were de-identified appropriately, date and time of the incident, detailed description of the event, clinical circumstances and contributing factors, immediate actions taken, follow-up care provided to the patient, preliminary analysis of root causes, and corrective actions implemented or planned. The risk manager recognized that the involved healthcare workers were experiencing significant emotional distress, the so-called second victim phenomenon. She coordinated with the Employee Assistance Program and peer support resources. Patient notification, as soon as practicable, is a legal requirement in Florida, and disclosure should not be delayed. Annual reporting to AHCA is mandatory, and failure to submit can result in penalties and regulatory scrutiny. Just culture evaluation should precede any disciplinary decisions, and punitive responses without system analysis perpetuate error risk. And finally, adverse incident reports submitted to AHCA are confidential and not discoverable in civil litigation with limited exceptions, encouraging honest reporting. Now let's move to our conclusion, which focuses on a commitment to lifelong learning and continuous safety improvement. The prevention of medical errors is not a static goal that can be achieved and then forgotten. It is a dynamic and continuous process that requires a steadfast commitment to lifelong learning, vigilance, and system improvement. The principles and practices outlined in this course, from the paradigm shift to systems thinking and the application of root cause analysis, to the cultivation of a just culture and the mastery of high reliability communication, are not simply requirements for licensure renewal. They are the foundational competencies of modern, safe, and ethical healthcare practice. The data are clear. Medical errors represent a profound and persistent threat to the well-being of patients in Florida and across the globe. Addressing this challenge requires moving beyond the outdated notion of blaming individuals and embracing a more sophisticated understanding of how complex systems fail. It demands that leaders create environments where staff feel psychologically safe to report errors and that all clinicians see themselves as active participants in identifying and fixing the latent vulnerabilities in their own work environments. For the Florida healthcare professional, this means internalizing the lessons of the Swiss cheese model, becoming proficient in the use of tools like SBAR, and paying particular attention to the high-risk areas identified by their respective professional boards. It means treating every act of documentation as a safety intervention and every near miss as a priceless opportunity to learn. Ultimately, patient safety is the responsibility of every individual who works in healthcare. By embracing the principles of continuous improvement and working collaboratively to build more resilient systems of care, we can honor our fundamental commitment to our patients. First, do no harm. Now we move to the Addendum, which specifically addresses the allied health professional's role in medication error prevention. This section is particularly relevant for occupational therapists and physical therapists. For occupational therapists and physical therapists, an indication is the reason for therapeutic intervention, while a contraindication is a specific situation where that intervention may be harmful. A critical and often overlooked source of medical error arises when a patient's medication regimen introduces new contraindications, such as dizziness or cognitive impairment, that transform a standard therapy into a high-risk activity. This module directly addresses the Florida Statute for Occupational Therapists found in Rule 64-B-11-5.0001 of the Florida Administrative Code and physical therapists found in Rule 64-B-8.002 of the Florida Administrative Code, which require education on contraindications and indications, including medication and side effects. Failure to manage these medication-induced risks is a preventable medical error, defined as the use of a wrong plan to achieve an aim. Professional bodies like the American Occupational Therapy Association and the American Physical Therapy Association identify medication management and review as a key therapist responsibility. This is critical during transitions of care, where medication discrepancies are common. Therapists are uniquely positioned to assess the drug-function interaction, the intersection of a drug's effects and a patient's functional performance. Failure to detect a side effect like dizziness on standing that is only exposed by functional tasks is a failure of this unique safety role. The failure to connect a patient's medication list to the therapy plan of care is a latent error, an accident waiting to happen. Let me walk you through several categories of medication side effects that serve as medical error landmines for therapists. First, let's discuss antihypertensives, diuretics, and orthostatic hypotension, which represents the fall risk error. Antihypertensive medications and diuretics are a significant fall risk factor, causing dizziness, dehydration, and muscle cramps. The risk is highest just after a new prescription or dose change. The therapy contraindication is that orthostatic hypotension is a direct relative contraindication to initiating transfers or ambulation without prior screening. The medical error, which is an error of omission, is the failure to screen. Omitting orthostatic vital signs, which means blood pressure in supine, sitting, and standing positions, on a patient with new blood pressure medications creates the conditions for a preventable iatrogenic fall. Second, let's discuss anticoagulants and bleeding risk, which represents the manual therapy error. Patients on anticoagulants such as warfarin or Eliquis are at high risk of bleeding. The therapy contraindication is that this creates a relative or absolute contraindication for interventions like aggressive manual therapy, dry needling, or high-impact activities. The medical error can be either commission, meaning performing a contraindicated modality, or omission, meaning failing to modify the plan of care to elevate fall prevention as the primary goal. Third, let's discuss opioids and benzodiazepines, which represents the cognitive and sedation error. These powerful central nervous system depressants cause sedation, dizziness, ataxia, and cognitive impairment. The therapy contraindication is that these side effects are a direct contraindication to therapeutic interventions that require patient learning, safety awareness, and motor control. The medical error, which involves flawed planning, stems from the fact that therapy is an educational process. The error is one of flawed professional judgment, attempting to teach a patient, for example, about hip precautions, who is cognitively impaired or sedated and cannot learn or retain safety-critical information. Fourth, let's discuss transdermal patches, specifically fentanyl and lidocaine, and thermal modalities, which represents the overdose error. This represents one of the most acute and life-threatening medical errors in rehabilitation practice. Regarding fentanyl, the FDA and the Institute for Safe Medication Practices have issued explicit, urgent warnings that applying direct heat, including heating pads, hot packs, hot tubs, or electric blankets, over or near a fentanyl patch is potentially fatal. Heat causes vasodilation and a massive rapid increase in drug absorption, leading to a potentially lethal overdose and respiratory depression. Regarding lidocaine, the risk is also present with lidocaine patches. Applying a heating pad over a lidocaine patch can significantly increase plasma concentrations, potentially leading to systemic toxicity including dizziness, ataxia, and tinnitus. This creates a latent error trap, as some newer patches may be worn after moderate heat exposure, while many others explicitly forbid it. The therapy contraindication is that this is an absolute contraindication for fentanyl. The thermal modalities that cause this reaction are used almost exclusively by therapy professionals. The medical error, which is an error of commission, is catastrophic. The safest and strongest prevention strategy is a standardized rule. No thermal modalities are to be applied over or near any transdermal patch. The therapist who applies a hot pack to a patient's back without first performing a thorough visual skin inspection and verifying there is no patch is committing a profound high-risk error. Fifth, let's discuss photosensitivity-inducing drugs, which represents the environmental error. A wide array of common medications, including antibiotics like doxycycline and ciprofloxacin, diuretics like hydrochlorothiazide, and NSAIDs like naproxen, are known to cause photosensitivity. The therapy contraindication is that this side effect is a direct contraindication for two specific therapy interventions. First, the use of UVB light as a treatment modality, and second, outdoor functional training such as community mobility or pediatric OT on a playground. The medical error, which involves flawed planning, is a failure to educate. An occupational therapist who takes a patient on doxycycline for an outdoor community reintegration session, without first verifying their medication list and ensuring and documenting patient education on sun protective measures such as a wide-brimmed hat, long sleeves, and broad-spectrum sunscreen, is directly responsible for the resulting iatrogenic phototoxic burn. Now let's discuss two case studies in OT and PT medical errors. Case study 6.1 is the orthostatic hypotension fall, an error of omission. In this scenario, a 78-year-old female is seen by a home health physical therapist 3 days post-discharge from a hospitalization for a total knee arthroplasty. Her past medical history is significant for hypertension. During the PT's evaluation, he reviews the hospital discharge medication list, which includes a new prescription for lisinopril 10 milligrams. The PT's initial evaluation focuses on the total knee arthroplasty. He notes the new medication but does not perform orthostatic vital signs, as the patient states she is feeling fine while seated. The PT then proceeds to gait training. Upon standing and taking 2 steps, the patient states, "I feel very dizzy, pales, and has a syncopal episode falling to the floor." The fall results in a new displaced intertrochanteric hip fracture. The error was failure to identify a high-risk medication change, a new antihypertensive, and the subsequent failure to perform a standard of care screening, orthostatic vitals, before a high-risk intervention. This is a classic error of omission. The active failure was omitting the orthostatic check. Latent conditions included confirmation bias, with the therapist focusing only on the knee and no EHR hard stop to flag the new high-risk drug. Prevention strategies using the action hierarchy include stronger prevention with standardized checklists for transitions of care and an EHR forcing function, a hard stop alert for new high-risk medications. Case study 6.2 is the fentanyl patch overdose, an error of commission. In this scenario, a 55-year-old male is treated in an outpatient OT clinic for chronic right shoulder adhesive capsulitis. His complex medical history includes chronic low back pain, for which he is prescribed 50 microgram per hour fentanyl patches applied to his upper back and shoulder area. The OT, running behind schedule, begins the session with a moist hot pack to the general shoulder and upper trapezius area. To save time, the OT places the hot pack over the patient's t-shirt, with the edge of the pack directly on top of the fentanyl patch. After 15 minutes, the patient reports feeling very sleepy and woozy. The OT, attributing this to relaxation, proceeds with manual stretching. The patient's respirations slow, and he becomes difficult to rouse, showing signs of an opioid overdose. The error was a catastrophic error of commission. The therapist applied a thermal modality, heat, directly over a transdermal fentanyl patch, a well-documented lethal contraindication. Analyzing this case, this is a catastrophic error of commission. The active failure was the application of heat without performing an adequate visual skin inspection. Latent conditions included ineffective training on ISMP warnings and a workaround, placing heat over the shirt, which eliminated the final visual skin check. Prevention strategies require mandatory ISMP competency training and a strict rule to document visual skin check performed. The strongest action is an engineering control in the EHR, a hard stop alert for any patient on fentanyl. Let me conclude this addendum with best practices for error prevention in therapy settings, presented as an actionable list. First, integrate medication reconciliation into every evaluation. Perform a full drug regimen review at every initial evaluation and transition of care. Second, use the 3-question review at every visit. Ask, any new medications? Any stopped medications? Any changes in dose? Third, implement a pre-intervention safety scan. Before any intervention, perform this rapid mental scan. For a vitals check, ask, is the patient on cardiac, antihypertensive, or diuretic medications? If yes, a pre-mobility vital sign check, including orthostatics if new, is warranted. For a skin check, ask, am I going to put my hands or a modality on this patient? If yes, a visual inspection of the skin is mandatory. Look for patches, new bruises, or rashes. For a cognition and alertness check, ask, is the patient on an opioid, benzodiazepine, or other CNS depressant? If yes, assess their alertness. If they are sedated, the plan must be modified. Fourth, leverage interprofessional communication using SBAR. You are the eyes and ears for drug function interactions. When you detect a problem, such as when a patient is dizzy, report it to the provider using a structured SBAR format. Fifth, prioritize patient education as an error prevention tool. The patient is the final line of defense. Use clear, teach-back language to connect their medications to their safety. For example, tell patients this new blood pressure pill can make you very dizzy when you first stand up. You must call for help before you stand up. Or, you have a pain patch on your back. You can never put a heating pad on that patch. It can cause a fatal overdose. Sixth, heed all high alert warnings. Treat all warnings from the Institute for Safe Medication Practices as absolute rules, not suggestions. This includes high alert medication lists, tall man lettering, and warnings on thermal modalities. This concludes our comprehensive course on medical errors for Florida healthcare professionals. Throughout this course, we have explored the patient safety imperative, understanding the global and national scope of medical errors and their devastating impact on patients, families, and the healthcare system. We have examined Florida's legislative response through Statute 456.013, which mandates education in root cause analysis, error reduction and prevention, and patient safety. We have learned a systems-based approach to understanding medical errors, shifting our focus from individual blame to system flaws. We have explored the Swiss cheese model of accident causation and learned to differentiate between active errors at the sharp end and latent conditions at the blunt end of care delivery. We have studied root cause analysis as the foundation of error investigation and learned to apply tools like the 5 whys and Fishbone diagrams. We have examined the action hierarchy to evaluate and prioritize solutions, understanding that stronger actions like forcing functions and automation are more effective than weaker actions like training and policies. We have discussed building a resilient culture of safety, including the principles of a just culture that balances accountability with system improvement. We have learned about the critical role of leadership and psychological safety in creating an environment where staff feel safe to report errors. We have explored high-reliability communication and teamwork through frameworks like Team Steps and tools like SBAR. We have examined medication and diagnostic errors in detail, including the management of high alert and LASA medications and the 5 most misdiagnosed conditions identified by both the Florida Board of Medicine and the Florida Board of Osteopathic Medicine. We have studied our ethical and professional obligations for reporting and disclosing medical errors, including understanding Florida's regulatory and disciplinary processes. Through detailed case studies, we have seen how multiple system failures combine to cause patient harm and have identified strategies for prevention at various levels of the action hierarchy. For allied health professionals, we have specifically addressed the therapist's critical role in medication error prevention, including the unique drug function interactions that therapists are positioned to identify and the absolute contraindications that must be observed, particularly regarding thermal modalities and transdermal medication patches. Remember, patient safety is not a destination, but a journey. It requires continuous vigilance, ongoing learning, and a commitment to improvement at every level of the healthcare system. By applying the principles and practices covered in this course, you can make a meaningful contribution to safer care for your patients and communities. Thank you for your attention and your commitment to patient safety. We will now review the exam questions to solidify your understanding. Question 1. According to the Swiss cheese model of accident causation, which of the following best describes latent conditions? The correct answer is hidden underlying system failures created by designers, managers, and decision makers that may lie dormant before combining with active failures to cause an accident. Rationale, the Swiss cheese model, developed by James Reason, distinguishes between active failures and latent conditions. Active failures are the unsafe acts committed at the sharp end by frontline providers, things like slips and mistakes. Latent conditions, however, exist at the blunt end of the organization. They are the decisions made by system designers, managers, and executives that create vulnerabilities within the system. These might include choices about staffing levels, equipment purchases, or training programs. The critical characteristic of latent conditions is that they can remain hidden and harmless for extended periods, sometimes years, until they align with an active failure and local circumstances to breach all the defenses and cause patient harm. Question 2. What are the 3 fundamental questions that root cause analysis seeks to answer? The correct answer is, what happened? Why did it happen? How can we prevent it from happening again? Rationale. Root cause analysis is a systematic, retrospective investigation method used after serious adverse events or close calls. The entire purpose of the process is built around these 3 foundational questions. First, we must establish the facts of what actually occurred through a detailed timeline and sequence of events. Second, we dig beneath the surface to understand why each contributing factor existed, often using techniques like the 5 whys to move beyond proximate causes to true root causes. Third, and most importantly, we must translate our findings into actionable recommendations that will prevent recurrence. Notice that the correct answer focuses on systems improvement, not on identifying individuals for punishment. This reflects the core philosophy of root cause analysis, which seeks to understand system vulnerabilities rather than assign individual blame. Question 3. According to the action hierarchy for RCA² recommendations, which of the following represents the strongest type of error prevention action? The correct answer is physical changes or forcing functions that make it impossible to do the wrong thing. The action hierarchy is a critical concept for patient safety because not all corrective actions are equally effective. At the top of the hierarchy are physical changes and forcing functions. A forcing function is a design feature that makes it physically impossible to commit the error in the first place. The classic example is removing concentrated potassium chloride from floor stock on patient care units. When the dangerous medication simply is not available, the error cannot occur regardless of how tired, distracted, or undertrained a staff member might be. Compare this to weaker interventions at the bottom of the hierarchy, such as education, policies, or warning labels. These interventions depend entirely on fallible human memory and vigilance. A nurse who was educated last year might forget. A policy sitting in a binder might go unread. A warning label might be overlooked during a hectic shift. Stronger actions eliminate reliance on human perfection, which is why they are always preferred. Question 4. In a just culture framework, how should an organization respond when a nurse inadvertently picks up the wrong syringe due to an unintentional slip? The correct answer is console the individual and look for ways to redesign the system to prevent the error. Rationale. A just culture framework recognizes that human error is inevitable and distinguishes between 3 types of behavior requiring different responses. The first type is simple human error, an unintentional slip, lapse, or mistake where the person intended to do the right thing but failed due to normal human limitations. The nurse in this scenario did not intend to pick up the wrong syringe. She was not taking shortcuts or violating known safety rules. She simply made an inadvertent error that any human being could make. The appropriate response is to console the individual, recognizing that she is likely already distressed, and then to examine the system. We ask, why was it so easy to pick up the wrong syringe? Could the syringes be color-coded? Could they be stored in separate locations? Could labels be made more prominent? Punishing simple human error does nothing to prevent future occurrences and actually damages the reporting culture that organizations need to identify and fix hazards. Question 5. A nurse is calling a physician about a patient whose oxygen saturation has dropped to 88%. Using the SBAR communication framework, which component would include the nurse's statement, "I am concerned he may be having a pulmonary embolism"? The correct answer is assessment. Rationale. SBAR is a structured communication tool developed to standardize critical information exchanges between healthcare team members. Each letter represents a specific type of information. Situation identifies who you are calling about, and the immediate concern. Background provides relevant clinical history and context. Assessment is where the communicating clinician offers their professional analysis of the problem. This is where clinical judgment comes in. The statement, "I am concerned he may be having a pulmonary embolism," represents the nurse's clinical assessment of what she believes is happening based on the data she has gathered. Finally, recommendation is where the nurse states what she needs from the physician, such as requesting that he come evaluate the patient immediately. The assessment component empowers nurses and other team members to voice their clinical concerns explicitly, which research shows improves patient outcomes. Question 6. Which of the following is a recommended best practice for managing look-alike, sound-alike medications? The correct answer is use tall man lettering to help differentiate look-alike, sound-alike drug names on labels and computer screens. Rationale: look-alike, sound-alike medications, often abbreviated LASA, represent a persistent source of medication errors. Drug names that look similar when written or sound similar when spoken can easily be confused, especially in busy clinical environments. Tall man lettering is an evidence-based strategy endorsed by the Institute for Safe Medication Practices and the Food and Drug Administration. It uses a combination of uppercase and lowercase letters to draw attention to the differences between easily confused drug names. For example, hydroxyzine versus hydralazine, or dopamine versus dobutamine. The capital letters create a visual speed bump that forces the reader to slow down and notice the distinction. Importantly, alphabetical storage should actually be avoided for LASA medications because it places them adjacent to each other on the shelf, increasing confusion risk. Physical segregation, prominent warning labels, and barcode scanning provide additional layers of protection. Question 7. According to the Florida Board of Medicine, which of the following is among the 5 most misdiagnosed conditions leading to quality of care violations? The correct answer is oncology-related conditions. As of early 2024, the Florida Board of Medicine identified 5 clinical areas that most frequently result in quality of care violations due to missed or delayed diagnosis. These are oncology, gastroenterology, cardiology, neurology, and infectious disease. The prominence of oncology on this list reflects a national pattern. Delayed or missed cancer diagnosis is consistently one of the leading causes of medical malpractice claims across the country. Cancer cases are particularly vulnerable to diagnostic error because early-stage symptoms are often vague and nonspecific, easily attributed to benign conditions. Additionally, the consequences of delayed diagnosis are often severe and clearly documentable. When cancer that could have been caught at stage 1 is not diagnosed until stage 3 or 4, the impact on prognosis is dramatic and undeniable. Florida healthcare professionals should be particularly vigilant about timely workup of potential malignancies and should ensure robust systems for tracking and following up on abnormal test results. Question 8. In the 5 whys example presented in the course, a patient received the wrong medication because the nurse did not complete patient identification because the patient's wristband had been removed and not replaced. What was ultimately identified as the root cause of this event? The correct answer is there was no process for checking printer toner levels or stocking replacements. Rationale. The 5 whys is a straightforward but powerful root cause analysis technique that involves repeatedly asking the question, why, to peel back successive layers of causation until the true underlying system-level root cause is revealed. In this course example, the chain of questioning proceeded as follows. The patient received the wrong medication. Why? Because the nurse did not complete the required patient identification check. Why? Because the patient's identification wristband had been removed for a procedure and was never replaced. Why? Because the wristband printer was not functioning. Why? Because the printer was out of toner. And why was the printer out of toner? Because there was no established process for checking toner levels or stocking replacement cartridges. This final answer reveals the true root cause, a system-level gap in supply management. Notice how the technique moved progressively away from individual actions and toward the organizational conditions that set up the failure. The nurse's failure to identify the patient was a proximate cause, but the root cause was the absence of a simple supply management process. Fixing the root cause by establishing regular toner checks and a restocking protocol addresses the problem at its source rather than relying on individual vigilance. Question 9. Which of the following is one of the 4 core teachable learnable competencies of the TeamSteps teamwork system? The correct answer is situation monitoring. Rationale: TeamSteps, which stands for Team Strategies and Tools to Enhance Performance and Patient Safety, is an evidence-based teamwork system developed jointly by the Department of Defense and the Agency for Healthcare Research and Quality. It is built around 4 core competencies that are specifically designed to be teachable and learnable. These 4 competencies are communication, leading teams, situation monitoring, and mutual support. Situation monitoring is the process of actively scanning and assessing what is happening in the clinical environment to gain and maintain awareness of the current situation. When all team members engage in effective situation monitoring, the result is a shared mental model, meaning that everyone on the team has a common understanding of what is happening, what the plan is, and what could go wrong. This shared awareness is foundational to catching errors before they reach the patient. It is important to distinguish TeamSteps competencies from other patient safety processes. Root cause analysis and medication reconciliation, while critically important, are separate patient safety methodologies and are not among the 4 core TeamSteps competencies. Question 10. For occupational therapists and physical therapists, which of the following represents an absolute contraindication when treating patients with transdermal fentanyl patches? The correct answer is applying thermal modalities such as hot packs over or near the patch. Rationale: this is a critically important patient safety issue for rehabilitation professionals. The Food and Drug Administration and the Institute for Safe Medication Practices have issued explicit and urgent warnings that applying direct heat over or near a transdermal fentanyl patch is potentially fatal. The mechanism behind this danger is well understood. When heat is applied to the skin overlying a fentanyl patch, it causes vasodilation, which is a widening of the blood vessels beneath the skin's surface. This vasodilation dramatically accelerates the rate at which fentanyl is absorbed into the bloodstream, producing a massive and rapid spike in drug levels that can lead to a potentially lethal overdose and respiratory depression. Sources of dangerous heat include hot packs, heating pads, hot water bottles, electric blankets, and even prolonged hot tub or bath exposure. For occupational therapists and physical therapists, this means that applying any thermal modality over or near a fentanyl patch site is an absolute contraindication, with no exceptions. Therapists must always ask about and visually inspect for transdermal patches before applying any heat-based treatment, and this precaution should be embedded in standard screening protocols. This concludes the exam review. The key themes running through these questions are consistent. Patient safety depends on building reliable systems rather than relying on individual perfection, communicating clearly and assertively as a team, learning from errors through structured analysis, and maintaining vigilance around the specific clinical hazards that affect your profession.